Kia ora. Good evening. My name's Hannah Denton from the Breast Cancer Foundation New Zealand, and tonight I'm delighted to be joined by Megan Pickett, Dr. Mike Russell, and clinical nurse specialist Sandra Sheen as we discuss breast reconstruction. Tonight we're going to talk about what's the best time to have reconstruction, what are your options, and what you need to know about surgery, treatment, and recovery. Tonight, hopefully, we'll cover all of this and allow time for your questions at the end. So welcome. Whether you're here because you're navigating your own treatment journey, supporting a loved one through theirs, or simply seeking more information, we're so glad that you joined us this evening. We're going to bring up some slides now, but first some housekeeping. We know that 7 p.m. can be a really challenging time of night for many people. So if you need to pop away and come back, we will be sending out this recording tomorrow and you'll be able to look at it in your own time. So I'll just whiz through the housekeeping slide that we've already covered off. And then, here we go. First tonight, we're going to be hearing from Megan. Megan was diagnosed in 2022 at the age of 43. Welcome, Megan. Why don't you begin by telling us a little bit about your journey with breast reconstruction and your breast cancer journey generally?
Okay, sure. As Hannah mentioned, my name is Megan. I was diagnosed with inflammatory breast cancer at the age of 43, almost 3 years ago, next month. In late 2022, I noticed that my nipple was raw, and then my breast became red and inflamed and swollen. I initially thought I had mastitis, but as I was breastfeeding my son, and I assumed that he had bitten my nipple. Poor guy. I went to my GP. He wasn't really worried too much as I didn't have a lump. But as he had a niece that had suffered from breast cancer at a young age, he suggested an ultrasound. I booked an appointment that following week because I'm very persistent like that, and it basically went tits up, for want of a better pun, in the room. I had a biopsy at the time, and a few days later I was diagnosed officially with stage 3, grade 3, ER positive, PR negative, HER2 positive inflammatory breast cancer. I started chemo 11 days after ultrasound. I had neoadjuvant treatment, so chemo first, surgery, and then radiation. I had 6 rounds of TCHP, with my last round being on the 4th of April. I had my mastectomy booked, a non-skin sparing radical mastectomy on the 8th of May, which just coincided with my birthday. So I got to have a night away from the kids, which was great. I had, that followed 13 rounds of Herceptin. I was one of the lucky rare ones that got some heart damage from the Herceptin treatment. So I had to pause some of that treatment for a couple of months. I then had 15 fractions of radiation therapy commencing in July 2023, and I finished that in August 2023. I was so super lucky to get a complete pathological response, which is quite uncommon for IBC, so very, very lucky. With regards to reconstruction, in my mind, I knew that I would get reconstruction. I wanted to feel complete. My partner had passed away 18 months prior to my diagnosis from cancer in 2021. And so I found myself single in my 40s, and in the back of my mind, I was sort of thinking long term around if I was to date again and have intimacy, what would that be like with just one breast? My breasts were tied into my femininity along with my hair. And I really struggled more with losing my breast than I did with the actual cancer diagnosis. To help with that grief, I actually got a casting made of my breast the week before my mastectomy. It really helped, along with therapy, with the grief of losing my breast, and it now sits in a box in the wardrobe, gathering dust. At the start of 2024, I began talking to my medical team about reconstruction. Implants weren't an option for me, so the only option I had was a DIEP flap, which is reconstruction using the tummy tissue to make a breast. I had surgery for that on the 14th of August 2024, and I was instructed to get fit and healthy to support with the wound healing, not to lose too much weight as they needed stomach for the breast, and I was lucky because I had 2 kids and I had plenty of stomach to spare. At my mastectomy, my surgeon had asked what type of scar I wanted. Did I want a straight scar or a smiley scar? I opted for a smile scar on the basis that it now sits underneath the breast mound, or my tummy tit, and not across it, so I don't look like I've got a little bit of a rugby ball. At my DIEP surgery, I contracted E. coli in the scar. That sort of set my healing back about 6 to 7 weeks. I was less mobile, couldn't get up and moving as quick as I would like to have. I needed antibiotics, and I've just got a little bit of pain in my ribs on my surgical side, which is likely due to radiation, but there was a lot of scar tissue that needed to be addressed because of the E. coli. With regards to recovery, I wore compression wear 24/7, high-waisted tights, so compression bodysuits and underwear. I opted for Lulu tights. They, you can pull them up really high. They don't have a middle seam, so you're not getting cut off. I had around 3 sets of active wear that I could have on rotation, so I could sleep in one, wear one, and have one in the wash. I slept with pillows all around me, like in a U shape, to help me sleep upright initially. There was a lot of consideration for logistics at home, especially being on my own with 2 little children. Online grocery shopping, because you cannot push a trolley around the supermarket, especially if you've got kids in it. I got a robot vacuum cleaner to vacuum and mop the floor. I'm not sure if that was just a deal I sold myself, but it was an absolute lifesaver. I moved items to sit at shoulder height in the cupboard, so I didn't have to lift anything from too high up. I used the dryer as well, as I couldn't hang washing or lift arms with my arms above my shoulders, so that was really helpful. With regards to revision, I've needed symmetry surgery. I've had a reduction on my right breast, and I've had the removal of necrosis in my tummy tuck. One thing that I learned was when you get a reduction, the breast becomes more angular as you decrease in size. So I haven't been able to go as small as what I would have liked on my original breast to keep the shape matching to the DEP shape. I'm now booked for fat grafting, which is actually happening next week, next Tuesday actually. I was supposed to be talking about getting a new nipple, but I need to have some more fat grafting first to try and boost the tummy tit. So hopefully by next Christmas I'll be done with a view of looking to get a nipple and then getting the tattooing and have that all completed. So it's been a long process. We're now 3 years to date. Look, supporting body image and mental health, the past 6 years since I had my children have been a lot. Losing my partner when my children were 5 months and 19 months old was pretty traumatic, and then my diagnosis, years of treatment and surgeries has taken its toll, but I'm still pretty positive. I see a therapist on a fortnightly basis. She's a specialist cancer therapist who has done lots of hospice work and end-of-life therapy as well, and she is really good for helping me with the correction of self-awareness, saying that it's okay to be tired, it's okay to ask for help, it's okay to not be who I was pre-diagnosis, which was basically go, 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 and to rest. Therapy's really helped me with my body image as well. You know, my body doesn't look normal as it did before, but it's a new normal, and the two things can coexist. I have bought some temporary nipple tattoos, which you just sort of stick on with a flannel. This has really helped to support my body image and my mental health. And it's not necessarily because I'm out flashing my boobs around, but it's really good for my mindset. I can hop out of the shower and catch myself in the mirror, and the nipple tattoo looks so realistic that it's like I've actually got one. I find now that I wear them all the time. I don't not have a day where I'm not having a tattoo on, and they last about five to 6 days. And for me, throughout this journey, it's about finding solutions that are personal and supportive to me, and that comes in many different forms, be it what people do see and what people don't see. Where am I now? Breast reconstruction is a journey. I'm still not there. I'm really, really thankful for the surgery and my new body. I feel sexy and feminine again. My body confidence is up. I actually feel better than I did pre-cancer. We're looking for silver linings. Going through treatment and surgery forced me to give up control and sit still for maybe the first time in my life, and that was a really big thing, to actually trust everybody in my little team around me, be it medical professionals, be it my friends and my family, to actually carry me through this thing. And there was some big stuff that happened, and there were little things like people making dinners for the kids. It's, yeah, you just kind of sit and be still and let the people that need to carry you, which was amazing.
Awesome. Thank you so much, Megan. You touched on it there, but it certainly has been a lot for 6 years, and we really appreciate you sharing that with us and showing a full span of the journey. I know I said we'd get to questions at the end, but I've had 4 come in that are just about the nipple tattoos.
Yes.
So where are they from? And I will put this in the email tomorrow for anyone who's after the same.
Sure. It's actually a company in Australia called Pink Lotus,
Mm-hmm.
and they also do tattoos that you can put over the scars and not just nipple, and they can customise them. So Australian-based lady, I think she runs it from home. Really amazing service. So yeah, I can give you the link to that.
Yes, please. Awesome. I thought I'd get that in there now before I forgot, because there was immediate questions about that. Keep those questions coming, and we will get to the bulk of them at the end once we've heard from Dr. Mike and from Sandra. Next up, we've got Dr. Mike Russell. Dr. Mike is an oncoplastic surgeon from Health New Zealand, Waitemata. He's going to talk tonight about your reconstruction choices, timing, and when options might or might not be best for you. So welcome, Mike. I'll just pass this along to you. Big arrow to move forward.
Yes. All right. Well, hi everyone. So my name's Mike. I'm a breast surgeon, and I work in public at North Shore Hospital, and in private at Auckland Breast Centre. And it's really a pleasure to be here to talk about reconstruction after mastectomy. It's part of the job that I really enjoy, being able to sort of walk through these different options with patients and really come to find the best option for each person individually. Hopefully by the end of this, you can have a bit of an understanding around the different techniques we use, the different timings we use, and some of the other factors that we consider when talking about reconstruction. What I'm intending is that this is an overview of the options and not specific advice. I think it's really important to have these discussions with your team, but I really hope that that this gives an idea of the different terminology to really help you have these discussions with your team. So what are we talking about with breast reconstruction? We're recreating the breast shape following a mastectomy, and we can do that using implants or your own tissue. We're aiming for symmetry and form. I think symmetry is a difficult concept sometimes, is that asymmetry is not normal in nature, but also that even with the best reconstruction, we can't achieve perfect symmetry. And so one of my colleagues talks about creating sisters, not twins. But we know that breast reconstruction, women who have been through it report an improved quality of life, improved body image, and improved self-esteem afterwards. And really that's regardless of the type of reconstruction that you choose. It's really an integral part of breast cancer treatment. Potentially historically, there's been an attitude that it's just a cosmetic procedure. Really, that's not how we think about things now. We think about it as part of, in the same, to the same level as the cancer surgery. We're thinking about reconstruction and the quality of life afterwards. We know that breast reconstruction is safe in the context of breast cancer, but we do consider a patient's health and the other treatment plans which will come into play after surgery as to whether these options are safe. We offer reconstruction both in public and in private, and about 30% of women in New Zealand undergo breast reconstruction, but there is significant variation still across the country. So the timing of breast reconstruction can be immediate at the time of the mastectomy or the breast cancer removal. This preserves the skin and potentially the nipple. And sometimes we use neoadjuvant treatment or chemotherapy before surgery to allow this. Delayed reconstruction needs at least sort of 6 to 12 months after radiotherapy, but there's no time limit. Currently, there are quite long waiting lists in the public system to have that delayed reconstruction, but that can allow time to complete the cancer treatment and to improve your fitness for surgery. So what are the benefits of immediate reconstruction? Well, we're doing the reconstruction at the same time as the cancer removal surgery. So there are potentially fewer surgeries. Most women who do have reconstruction do need some further revision surgeries afterwards. So it's not saying that we're going to do it all in one, but it is from a practical point of view, more efficient to do the reconstruction at the time of the mastectomy. I think Sandra might talk about the thresholds for BMI around reconstruction in the public system. We have different thresholds for delayed versus immediate reconstruction, where delayed reconstruction, your BMI needs to be below 30, and for immediate reconstruction, below 35. And that's really because of the increased risks of complications over those levels. I tend to find that when women between a BMI of 30 and 35, it's very hard to lose weight after surgery, particularly if you need to go through chemotherapy. So if you're sitting in that threshold between 30 and 35, that may be a reason why we err towards an immediate reconstruction. To go through reconstruction, we can't have people who are smoking just because, again, of the risk of complications. And in terms of the baseline level of health, you need to be healthy enough to go through this major surgery. And we do consider if you're having radiotherapy, particularly after surgery, that can impact on whether an immediate reconstruction is recommended. So generally, if radiation therapy is needed, we need to move towards a delayed reconstruction. So when would we use a delayed reconstruction? It does allow time to stop smoking and to lose weight or even put on weight before a reconstruction. It allows us time to complete the treatment plan around what chemotherapy, radiotherapy is required, and gives better certainty around what's going to be needed. And it allows time to decide on the type of reconstruction and really separates that decision from everything that's happening around the cancer journey. We would recommend a delayed reconstruction when immediate reconstruction is contraindicated or not able to be used. Some of those things would be around whether you're smoking, if your BMI is over 35. Inflammatory breast cancer is a reason why we wouldn't do immediate reconstruction, and if there's current infection. And particularly if there's radiotherapy, as I said before, that can cause some issues around the reconstruction.
Can you click on the actual presentation? Thank you. Sorry, team, it appears the slides weren't working. Hopefully they're working now. Use the mouse. My trackpad doesn't work. Yes. Yeah,
Cool.
perfect. So we've got some thumbs up.
Good.
Beautiful.
All right, so this is implant reconstruction. So we're using silicone implants usually, or expanders with saline. And the implant can be placed in front of the muscle or below the muscle, the pectoral muscle on the chest wall. And that picture on the left shows the different positions of the implants. There's a general shift towards placing the implants above the muscle currently, but there are pros and cons to each. One of the benefits of implant reconstruction is that it's a shorter surgery and recovery. It really adds 40 minutes to an hour to the surgery. We generally don't like to use implants around radiotherapy. Smoking is another reason that we would not use an implant. The risk of infection is a really major issue with implants. And although it's very rare to lose an implant to infection, it's a major thing for someone to go through. So we try to avoid that or optimize things as much as possible before this. Implants as well have a lifespan, generally in the sort of 10 to 15 year range. And that's not to say that the implant needs to be removed at that point, but just to give an indication that often women will need to go through a second surgery at some point in the future to revise things and to replace the implant. Other risks, I guess, of an implant reconstruction is capsular contracture. So around an implant, your body will form a capsule. That's a normal thing for the body to do, but for some patients and for a number of different reasons, that capsule can tighten around the implant. That can change the shape of the reconstruction and also cause some symptoms like discomfort. Rippling is an issue we see with the placing the implants above the muscle, and that's really just seeing the contours of the implant beneath the skin surface. ALCL is something that we talk to all patients about around the time of an implant reconstruction. That's a type of lymphoma which has been associated with implants. Really, it's the older generation of textured implants which we used to use. The newer generation of these nano-textured or micro-textured implants haven't had any cases associated with them, but it's something that we talk to all patients about. Really, even though there's coming up on 15 years of use of those implants, we don't have the really long-term data to say that they're completely safe. Autologous reconstruction just means using your own tissue to reconstruct the breast. And the tissue is taken from other areas in your body, primarily the abdomen, and that's the DIEP or DIEP flap. Tram flap is the sort of older form of the DIEP flap where they used to use muscle. LD or latissimus dorsi flaps, and a tug flap, which I haven't seen used much in New Zealand, but I've seen a few women have that in Australia. That's using tissue from your thigh. The benefits of an autologous reconstruction is a more natural feel using natural tissue. Typically, it does better with radiotherapy. We still don't like to give radiotherapy to it if we can help it, but it tends to do better. And some people talk about a tummy tuck with things like a DIEP. I'm not sure that that's the same operation that you'd have if you had a tummy tuck for aesthetic surgery, but it does flatten the stomach, which some people think is a good thing. Where we can't use an autologous reconstruction is if people don't have enough tissue to recreate the volume of the breast. Vascular issues. So all of these flaps rely on good vascular supply or good blood supply. And so before surgery, the plastic surgeons will generally always get a scan to show those blood vessels and to make sure that it's safe to go ahead with the surgery. And then other background factors can increase the risk of the flap failing. Those can be things like diabetes, increased BMI, and smoking. And so that's why these things come into play around whether or not we would recommend these as a good option for some patients. Because we're taking tissue from other parts of your body, that body area can have its own issues. And so one of the downsides of the tram flap historically was the risk of hernia. Thankfully, the DIEP flap has a much lower risk of that, and also some weakness of the muscles. If particularly the LD reconstruction does take the muscle, the latissimus dorsi muscle from the back, generally the other muscles will compensate, and so most people, from a functional point of view, find that they can manage most of their previous function. And these are just some general pictures of the different reconstructions. On the left, the DIEP flap taking tissue from the tummy and then disconnecting the blood supply and reconnecting it in the chest. The latissimus dorsi flap is taking the skin fat and muscle from the back and then swinging it round onto the chest wall to recreate the breast shape. And so just in general terms, the implant surgery is quicker with less scarring and no donor site, but some people find it's less natural. I think you're more likely to need revision surgery, and it's difficult to match synthetic tissue to natural tissue, and so often we'll need some symmetrization surgery. really the implant will stay essentially the same shape whether you're in clothes or not, and so it's really to try to match to give the same shape and size in clothes is really the goal for an implant reconstruction. Autologous reconstructions take longer and I guess more upfront cost and investment from the patient's point of view around the time for recovery. But they tend to be a more natural reconstruction that ages with you and also changes with your weight. And so different people will choose different options based on their own life stage and what their priorities are, but also around the other treatment plans that they have for their breast cancer. So when we talk about revisions, fat grafting is often something that we use and more. We can improve the feel and the look of the reconstruction using this, and this is performing liposuction at other areas of the body and then re-injecting that fat into the skin. That does add more surgeries and is not available everywhere. Nipple reconstructions are generally offered as it sort of completes the aesthetic aspects of the reconstruction. Often we're making a flap of skin, which is basically to create the projection of a nipple, and then tattooing around that to make it look like a normal nipple and areola. I think it sounds like the tattoos that you're using are probably better than this picture here, but that's an older version of stick-on nipples, which can be used, I guess, as without needing to go through further surgery. And really, there's no major contraindications or reasons why we wouldn't offer this. And so I think it's often something that we'll offer, towards the end of the reconstruction journey. I'd always talk about the option of going flat or not having a reconstruction after mastectomy, and it's a very reasonable choice for some people. With this concept of an aesthetic flat closure is something that's sort of gained a lot of attention recently, and really what that's talking about is doing a standard mastectomy with an eye towards how the final scar is going to look and feel, and aiming for a smooth chest wall after that mastectomy. The benefit of going flat is that there are fewer surgeries, it's lower risk and a quicker recovery. And there is the option of having a reconstruction later if that's what's wanted as well. We would recommend it as the best option when there are reasons not to have a reconstruction. I think it's important though when talking about these aesthetic flat closures that achieving a perfectly flat, smooth chest wall is not always straightforward, and I think it's important when looking at photos of patients who've had similar surgeries to really be comparing the patient's body shape to your own, and so even though it is a more simple option, it can require revision surgeries to get a good flat result.
Awesome. Thank you, Mike, for sharing that with us. Lots and lots and lots of questions are coming through, so we will get to them later, but I just want to cover off a couple before we move on to Sandra. So the first one is reconstruction safe for breast cancer? So when you were looking afterwards for surveillance and checking for recurrence, is a breast reconstruction safe?
Yes. Yeah, is the short answer. I think the only thing is that we're always talking about the general, on average. And I guess one of the fears that as an individual person going through breast cancer treatment you can have is that, particularly if you're having an immediate reconstruction, you don't know if you're going to be that 1 or 2% that's going to have an issue, which there are people who have their breast cancer treatment delayed because of complications. And so I think it's something to consider that while we aim for the best outcomes, some people don't have those sort of perfect outcomes, and that can impact on the treatment. But on average, yes, it is safe.
And I'm thinking Sandra will cover this off, but we've had a question about whether or not the revisions and the graftings can happen in the public system.
Yes. Yeah. And there's no time limit on that, whereas in private there often is a time limit. And so I think that's
Okay, cool. So as I said, there's lots and lots of questions and we'll come back to them. But we're just going to carry on with Sandra. So Sandra Sheen is a clinical nurse specialist for breast reconstruction at Health New Zealand, Counties Manukau. And Sandra, you support women every day as they make these choices and undergo breast reconstruction surgery and navigate these social and physical implications and challenges as they move through it. So can you share with us a little bit about your role and the women you support and what happens in that first specialist appointment?
Thank you so much. Hi everybody, it's great to be here with you. I'd like to thank Breast Cancer Foundation for inviting me to join with you this evening. As Hannah said, I work for Health New Zealand Counties in the plastics department. We provide a northern regional service for breast reconstruction. And the information I will be sharing with you is about this service. I can't talk about other services. However, the talk is quite general. My role is quite general, so I would assume that you would find other services near to where you're living across New Zealand. Our service actually provides all types of breast reconstruction. So we provide implants right through to autologous using your own tissue for reconstruction. Oh, sorry. So my role, what do I do? My role is a very supportive role, I feel. I mean, the role is very much a role that I can adapt to try and meet the needs of individual women, the healthcare needs that they may be requiring when they come into the service. The role, therefore, encompasses a holistic approach to ladies' well-being. So, physical support, we look at if ladies come, they might have a painful breast where they've had biopsies already, bruising, so making sure that they've got supportive bras, things like that, that they've got pain relief, being aware of body image when ladies come in to see us. Obviously, they're exposing themselves to us, and all of these things are new. So making sure that we maintain dignity throughout our encounters with patients is really important. I provide emotional and support. We can refer to the cancer services, psychologists and social workers. And we also refer to the Breast Cancer Foundation New Zealand if women are requiring support. So we have the links there. We also provide information. As soon as I get a referral for a lady, my role is to continually provide information about what's happening, where it's happening, what time it's happening, right the way through, until sometimes we discharge ladies. But we always say that we're always there. Even if a lady's discharged, we're always there. My phone, I've always got my phone. If they want to ring and ask for any support, then I'm there. We provide lots of written information as well. We provide that within our consultations and for discharge about nipple reconstruction, about nipple tattooing, about 3D nipples, fat grafting. We have lots of written information, but we always back that up with talking pictures and things like that. We also look at the cultural and spiritual needs of ladies, identifying the cultural background, practices, beliefs, and ensure that this is integrated into care. I think that's really important. And I think at counties we do, I think I can say we provide a very good service around cultural support, but always maintaining dignity and being respectful to what ladies' needs are. So also is looking at community support. what's available to ladies. People come from different social backgrounds. They may not have the support around them that we would want them to have when they're having their reconstruction. So it's just making sure that everything is there for them. And I must say, it is a privilege for me to work in this role. I work with some wonderful ladies going through some distressing times, but coming out the other end and feeling like it does. So making a decision about breast reconstruction is one of the big things. You've been diagnosed with cancer. Should you have reconstruction or shouldn't you have reconstruction? I think the first thing that you need to do is to discuss with your general breast surgeon, because the general breast surgeon will be with the person that's dealing with your cancer treatment. And we always say that cancer treatment is the most important thing to deal with. So they will tell you if they feel it's safe for you to have reconstruction immediately, or whether they would suggest that you are having treatments which would suggest that it would be better for them to wait. As a plastic service, we do not accept some referrals for immediate breast reconstruction for the following reasons: smoking, vaping, and using nicotine products. If your BMI is above 35, you must be generally healthy, and the treatment plan after surgery, if there's radiation planned, then we wouldn't offer you immediate reconstruction. And the reason for that is that radiation treatment causes damage to the cells, which can cause problems with your skin. And if we were to make you a really lovely new breast and then treat it with radiation, there is risk of damage to that new breast. So we believe that having reconstruction at a later time is preferable. So immediate reconstruction, we receive a referral from the general surgeons, and you can always ask for that referral. Even if the general surgeon may not think, you are able to see a plastic surgeon to have a discussion about immediate breast reconstruction, whether that is an option for you or not. But it sometimes can help with decision making. You will come for a first specialist appointment. In our service, the appointment takes approximately an hour. You can bring a support person, you can take notes. You'll meet the plastic surgeon, and you'll ask questions about your health, family, work, if you've had any other illnesses, any other surgeries, whether you drink, whether you don't drink, whether you use recreational drugs, all of those sorts of things, because then that surgeon will have a good overview of your support systems, what your hobbies are, which we need to consider when we're thinking about reconstruction. The surgeon will then examine you, and then you'll have a long discussion about the risks of surgery, the different types of surgery, the options, the risks of each surgery, the benefits of each surgery. And hopefully by the time you've gone through that part of that meeting, a plan will be agreed about what type of reconstruction that you would like to have, and they're happy to provide you with. Some people can't always make a decision on the day. So with immediate reconstruction, we do always make a second appointment so that you can come back, you can have some time. We don't want rush decision making, because you may not make the right decision. And I always advise that it is about what the lady wants, not about what anybody else thinks. So husbands are quite vocal sometimes about what they prefer. I can go bigger, but the lady's saying go slow, smaller. So I think it's good to take time to really make the best decision for you when you're deciding what surgery you're going to have. So you get given more information about all of the different pros and cons, the surgeries to take away with you. I always give information about post-surgical bras that you'll need, as well as my contact details, and tell ladies that I'll be their go-to person. So delayed reconstruction, can I have delayed reconstruction? Yes, if you're not smoking or vaping. Your BMI must be below 30. Lots of ladies ask why ladies that are having immediate surgery can have a BMI of 35, and it is quite contentious, but if you're having a delayed, it's 30. The reason for that is because we know that 30 is quite optimum. So it reduces your risks of other problems associated with having a BMI. We know that ladies that have immediate surgery only have a couple of weeks before surgery, but they're not going to, if they've got a BMI of 35, they're not going to get to 30, whereas delayed ladies do have that time. However, I acknowledge that it's difficult sometimes for ladies to get down to that BMI of 30. And especially when you're taking hormones and all of those things, and it can be, I think, a disaster for some ladies when they want to get on and have the surgery. You need to be generally healthy. You must be a year post radiotherapy, which is why I've said. We also, with the delayed reconstruction, we don't actually offer implant reconstruction because the damages to the skin are permanent and they keep on. And as Mike said, with implants, you can get contracture and those sorts of things as a consequence of having radiotherapy. Inserting an implant in, they can quite quickly get contracted and go tight and lift up, so that they're not as the look is not as nice as if you didn't have radiotherapy. So we usually offer some form of autologous reconstruction. Can I just go back to the BMI of 30 and 35? One thing that we don't think about very often, but we have a lot of women that have a BMI of 18 or very low BMI. They haven't got any fat anywhere on them, and it's very hard to offer all of the types of reconstruction when there is no tissue to be used for an autologous reconstruction. And so that can be as difficult as well. We also ask ladies to go and see if they can put some weight on. So there is problems both ends of the scale there. If you're having delayed reconstruction, no long haul flights for 6 weeks before or after surgery. That's because of the risks of flying, which is thrombosis, like blood clots in your calves or in your lung. And we know that the risks are lowered if you wait for that period either side. So you can have delayed reconstruction at any time, as Mike said. And it may be 10 years after when you think, oh, okay, it's the right time for me to do this now. And we see ladies at any time. You wait 20 to 30 weeks in our service to be seen for a first specialist appointment. You're then placed on, you see the surgeon, and then you're placed on a planned surgical wait list. And the wait time for delayed reconstruction varies across New Zealand. We are trying to get the wait in our service down to a year, but that can be, as I said, different in different places. I'm aware that people are maybe waiting much longer, and I know that this timeline can be very scary, frustrating, and we have ladies that put life on hold because they want to be whole again. And it's a big part of my work. It is supporting these ladies and making sure that the service is around for support. So preparing for surgery, either surgery, making sure you're as well as possible, keeping healthy, walking, exercises, having a healthy diet. We do discourage ladies, when we accept them onto the list for surgery, we discourage ladies from trying to increase or lose weight at that time, so not going on a keto diet if they've got the right amount of tummy to use for a breast. We don't want them coming in on the day of surgery with no no tissue to use. It's quite frustrating. And stopping dietary supplements that could cause bleeding, turmeric and things like that. So if you're at all not sure about those, then a discussion with your surgeon will tell you what you can take. Usually we just say stop for a few weeks before. The other thing that can cause surgery to be cancelled on the day are things like getting skin problems. If you have skin problems, it's making sure your skin is healthy as possible. If you get psoriasis or things like that, trying to keep on top of managing that. We also looking at social needs. What about work? Are your work supporting you? Having time off? If you're having the tummy operation, you're looking at 12 weeks for full recovery. We have lots of ladies from Northland arranging transport, arranging accommodation for them and their family while they're with us, and the ladies are having surgery. They want support people there. As you said, a support with meals, preparing meals, who's going to be at home. With some of these big surgeries, recovery can take a while. Do you need to see a social worker? How is this going to impact on you generally? So as I said, recovery is different for each type of reconstruction. It's also different for every person. After surgery, I see every lady that's had breast reconstruction, and we have a booklet which goes through all of the do's and don'ts advice following discharge, and I spend probably about an hour going through this, and I think when people have had the big surgeries, they get quite anxious about going home because there's a lots of attention on the ward, and going home can. However, some women are just desperate to get home out of the hospital. But the do's and don'ts are: don't put a hot water bottle onto your breast or your tummy if you've had an DIEP or an implant, because your sensation will have changed. Don't put a hot water bottle in there because you're going to get a burn. Just little tips like this, knowing when the district nurses are coming, knowing when you're going to get your appointment for follow-up. And then I carry on. I phone ladies on day 1 of discharge, day 3, until they see a registrar for just a post-op dressing check, and then they come back to see their surgeons, and then it's you phone me if you have a problem. I get lots of phone calls if ladies do have problems with wounds, with infections. And just managing that. Sometimes a GP can manage a problem, sometimes they have to come into hospital. So thank you.
All right, so as I said, there's a lot here. Thank you so much, Sandra. There's lots of information there. The first question was around, is there one of you somewhere else in the country? And there will be in certain places, and we acknowledge that a service like Sandra in Counties Manukau provide is wonderful, and it has really good wraparound service. You'll need to talk to your team about whether or not there's a clinical nurse specialist in an area like Sandra. Someone has asked, is breast reconstruction provided for in Northland? And the public system, Sandra's service is from Northland down to Counties Manukau. So let's get stuck in. Someone has said, is there a difference in BMI requirements between public and private? Some people have been accepted higher in private than public. So yes or no, Mike, do you want to?
There's the restrictions are there because of the risk of complications, and so that's the primary thing that people are looking at, but in both public and private. But in private, there are no hard limits on things, and so there's a little bit more flexibility with that. But I think as you say, that the extremes of BMI do increase the risks, and so that's there are even in private there are BMIs where we would say that's not the right thing to do.
Yeah, so it's usually an individual surgeon's choice, and I don't think it's just the BMI that will be taken into consideration. I think there will be other things as well. So maybe accepting a higher BMI, but health's really great. They're running marathons and things like that. Their cardiovascular system's really good. So yeah.
So another question then, just about lymphedema and the option of having autologous reconstruction afterwards. Does lymphedema affect the ability to be able to take that? I mean, specifically probably the latissimus dorsi reconstruction, but are they able to get good?
Yeah, I mean, so I don't do autologous reconstructions, and so that's probably a question specifically for the plastic surgeons who do that. But
so they do reconstruction. They do the latissimus dorsi and the tummy. I mean, that sometimes there's actually an improvement of the lymphedema because of the surgery, but it isn't something that would stop surgery.
Okay. Scrolling up, lots and lots of questions. My chest is quite concave. Will this change over time? And also this person has noted that when they've had surgery, they started with a lumpectomy and then had a mastectomy later, that they had a lot of bleeding. Is this going to be an issue if they have a reconstruction? Would the surgeon be concerned about the bleeding?
Depends what's caused the bleeding, I guess. There are some people do have reasons why they have an increased risk of bleeding, but also bleeding is just a risk after any surgery. So I guess that's something to go through with the surgeon. Generally, the concavity that we get after a mastectomy, that's part of what the reconstruction is aiming to address and to fix. And so generally that can be improved, but it's hard to say for sure without being directly.
I've had a couple of questions for you, Megan, about what you used in the time period between your mastectomy. What did you use on that side of your breast where you were flat before you had the reconstruction?
So I was given some foam sort of prosthesis type things that I would stick inside my bra until I had finished radiation, and I got a prosthesis from a company called My Reflections, which was funded through THB, I think. Let me get some funding. And so I had it was beautiful to wear. It was light, soft, it sat inside the bra or against the skin, and you could get different types of backings. It's flat or molded, so you could sweat or what have you. And it was a perfect fit. They sort of scan your body with a foam actually, and then they 3D print. So it fits right into your concave skin and everything, so it looked completely real. The only time that you could tell that it was in there is if I was wearing a singlet that was too low, and you could see it. But yeah, so I just use prosthesis most of the time.
I've got a question here, Sandra. You'll probably be able to answer this one. With the DEP reconstruction, do the surgeons use mesh in the abdomen donor site?
Good question, because women do worry about mesh, and I know that the surgeons. Sometimes mesh is used with implants as well. Mike will tell you. With the DEP, they would only use it if they had to strengthen the abdomen, I think, during surgery. So if they were concerned that there was a risk of hernia, then they may use it, but I think it's quite rare. I think we probably use it with implants. But what the surgeons always say, they only use it if they need to use it, if there was any worry about hernia, and with the implants, it's to hold and help support a breast implant. It's different to when mesh is being used internally. I think you're talking about the gynecological. Women do worry about that, mesh and gynecological. It's a totally different way the mesh is being used. It's being used externally to hold something. It's not being used internally. So the risks are just not the same, and there aren't the same problems. So yeah.
I've got one question here for you, Mike. Had an implant after mastectomy, was followed by radiation, and as a result has had the capsular contraction, and it seems to be getting worse and the breast tighter over time. Is this something that could be revised in a minor way, or does it require a full reconstruction and another implant?
It's really hard to say for sure what's needed, but generally that if there's a true capsular contracture, then it often does need a proper surgery to fix that. But it's I guess those surgeries are easier to recover from than the original mastectomy and reconstruction. But
What I'd say is pop to your GP, let your GP have a look to confirm that they might think it's capsular contraction. Then the GP can refer back to a service, either a plastic surgery or the surgeon you had, and then really they need to have a look and see what's going on and make a decision with you about the best way forward.
I've got a question about iron levels ahead of reconstruction. Should they be factored and considered? I mean, with delayed, you've got a little bit of time to correct those and test those, but how much does iron play a role in what the surgeons are worried about?
I mean, for a lot of these surgeries, I don't routinely test it prior. I think as long as your hemoglobin level's okay, then the risk of major bleeding during surgery is very low. Really, if that happens, you often need to have blood transfusions. And so iron levels, we want health to be as good as possible prior.
We do check things like hemoglobin, which is the red the red blood cells after surgery. Actually, with these surgeries, they're very outside of the body cavities. There's a very low risk of bleeding, even with the DIEP. And the surgeons started doing now, I've said, with a long surgery, it doesn't equal death. People think that they're going to die because they just have this feeling that it's a long surgery. And I always say, you're not going to bleed, you'll come through this okay. And that can be really reassuring, and people just sort of like take a deep breath and go, because I thought, there was a risk of dying. Yeah. And the other thing is that it comes back to the other question about, preparing for surgery. If the surgeons feel that there are any risks, they will consult with others. They don't make this unilateral decision, yes, they will actually consult with haematologists if you have haematology problems, the respiratory team if you've got breathing problems. And you will, if needed, have an anaesthetic review, and the anaesthetist has to be happy to give you an anaesthetic. So we try as hard as we can to get you your surgery.
I've got another question, and it was for you, Megan, around when you went into it, did you realise or fully comprehend that it would be 3 or 4 different surgical procedures, and how have you reconciled that as you've gone along, how you've dealt with your own mental health as it's been more than one?
Yeah, no, I was fully aware that it would be multiple surgeries. And I was aware of the time frame. I think because IBC, you don't have the choice of immediate or delayed. It's always delayed. So in my mind, I had set a bit of a milestone that week, right, by 2024, I'll be finished. And then 2024 came around and I still wasn't finished. And so right by the end of 2025, I'll be finished. And we're still going to 2026. The sort of silver lining for me is that every time I go in for surgery, I know that there are checks done, and I can sort of get a little bit more reassurance that the cancer's still kept at bay. Each surgery that I go through, it's less and less and less, and the recovery is shorter and shorter. So it's kind of like, Rome wasn't built in a day, and neither is my breast, and it's a journey, and I'm okay with that. Yeah. I'm just grateful to be able to have the opportunity to have one.
I think I can add to that in it is never one surgery. Our plastic surgeons always are up front and say never one. It may be just 2, but it all depends, if there's significant asymmetry, if you need a nipple, if you want to have nipples made, if you want tattooing in the public service, it's not, these things are, there are delays, and it's just one of those facts that I'll be honest with you, we don't do things very quickly, but also if you have a DIEP surgery, we say we're not going to do anything for a year because we let that let that breast do what it's going to do in respect. Sometimes they drop, and things can change. So any surgery, we want to match as closely as possible. So there are weights.
Yeah, my surgeon was very upfront about that. Yeah.
And the other thing about nipples, we do 3D nipple tattooing now. So you don't have to have a nipple made surgically. Our service provides the 3D. So that's another thing that can be available.
Yeah, I've heard a surgeon, breast reconstruction, a plastic surgeon, say that the nipples are cherry on the top, and so
That's quite large,
the cherry on the top. And anyway, we've got about 2 minutes left, so I'll quickly rapid fire another question. Let's just have a look. There are a lot of questions, and I just want to acknowledge that there are some discrepancies around the country and what's available and wait times. We are aware of some of these issues, and they are a big part of our advocacy work at the Foundation around these delays and this time. Our nurses are available to have a chat about your options, and at the end, once I ask these last couple of questions, we'll pop up a slide with the nurses' contact details. But it is unfortunate, and we do know that, as many of you have referenced in the comments section about a postcode lottery, it is different in different areas, and we know that. So one last question, let me find a good one, and maybe you can all answer it. That's not to say not all of the questions are good, they're all great questions. I'll rephrase it, an easy one for us to answer to finish. There was one around, I've had a mastectomy, and obviously with a delayed mastectomy, there's less skin afterwards. I'm assuming this person had a radical mastectomy. There's less skin afterwards. Does that mean that they'll have to take more from my tummy because there's no skin there?
So no, we take the skin, or the plastic surgeons take the skin as part of these autologous reconstructions. So the skin then, I don't know the best way to put this, but it gets shaved off the top of the tissue that we take. So any excess skin that's not required gets shaved off. So so we can use the donor site skin to recreate the breast skin.
If you choose to have implants, there is a step that has to be gone through because you have lost the skin. We can't just push an implant in there. So it would be a 2-part process where an expander is inserted, which is like a plastic bag. It's inserted into the breast, and then it's every couple of weeks some fluid is put into that little bag, and as it expands, the tissue expands with it, so it gives the tissue, and then that's removed, and an implant would be put in its place. And with the tummy, you can only use what's there. So it's just sort of like a ellipse of skin just around the tummy button, and that's used. But usually they get a very good result.
I think
Megan says she can do.
Yes.
Thank you so much, all three of you, for answering those questions. There's a lot of information in there, and as I said, this is being recorded, so hopefully you can digest that over the coming days as we send it out to you. In a moment, Eve's just going to pop up our final slide with the nurses' information. Hopefully that's coming. Yeah, and then Sandra, can you just press the next button on that? You need to click on the actual presentation, Eve. Here we go. Perfect. So, as I said, the number's up there. You can call our nurses anytime between 8:30 and 4:30. We will also be sending a survey at the end of this with the recording tomorrow. And in it, there's an option to leave your contact number, and one of the nurses can reach out to you. If you're not there already, I know many of you will be, you can join our online Facebook community. And that's moderated by a wonderful team of nurse specialists. And it's a fabulous community of women going through the same journey who can help and who can understand. That's it from us here. Thank you for persevering with the slide. Technical difficulties at the start of the evening. It's been my privilege to present this to you tonight. Thank you to Megan and to Mike and to Sandra for being here this evening, and to Eve for helping with the technology in the background. Ka kite, and we'll see you next time.